Good day, everybody. I am honored to welcome all of you to join this joint session between the World Society of Arrhythmias and the Asian Heart Society. We have a distinguished faculty panel here today, and we're hoping for a very vibrant and interesting discussion. Today, our session is focused on anticoagulation in atrial fibrillation. We have titled this 2024 Goals, Guidelines, Gaps, and Getting It Right. And we want to address within this session a number of items relevant to the treatment of atrial fibrillation and the role of anticoagulation therein. I am co-chairing this with Dr. Roin Rekvava from Georgia. Dr. Rekvava, good morning or good afternoon where you are. Do you want to say a few words about the introduction here, and then we'll get started?
Good morning, everyone. Good afternoon and good evening. We are from several countries, and let me say hi for all of you. From this 4G, for me personally, is more important gaps in guidelines. That's why I'm focused on gaps now today. So I have my goal. So let's start, and we'll see who will show us the gaps of guidelines. Thank you very much.
Thank you very much, Roin. Our process today is we're going to start off with a keynote presentation, and then we're going to follow with 3 case presentations. We are very honored to have with us today Dr. Mina Chung from the Cleveland Clinic in Cleveland, Ohio. Dr. Chung is a good friend of mine, and I've been honored to know her for quite a while. She is the first vice president for the Heart Rhythm Society, and she was also the vice chair on the recent 2023 ACC, AHA, ACCP, HRS guideline document addressing this topic. So Mina, welcome. Look forward to hearing what you have to say.
Thanks so much for that very kind invitation, Tom, and it's a pleasure for me to be here. Are you seeing my full screen?
Yes.
Yes.
Okay, thank you. So what I'm going to do is give you a brief update on oral anticoagulation from the recent 2023 ACC, American Heart Association, American College of Pharmacy, and Heart Rhythm Society guideline for the diagnosis and management of atrial fibrillation. So from that document, we will focus on highlights of anticoagulation. And I want to thank the writing group in advance, and also especially Dr. Jose Hoglar, who is the chair of the document. So one of the first things that you'll notice with the guideline, and that may be a little different than prior guidelines, is that we tried to focus decisions based on annual stroke risk rather than a specific score. Now, our most commonly used risk scoring system is the CHADS-2-VASc score. We're all familiar with that. We don't really change the recommendations with regard to CHADS-2-VASc scoring. Obviously, we recommend using it because it's the CHADS-2-VASc or another validated risk classification score. It's class 1 recommendation, and but we divide the stroke risk into high, which would be greater than or equal to 2% per year, which equates to about a CHADS-2-VASc score of 2 in women, in men, and 3 in women. And in this category, anticoagulation is recommended to prevent stroke and systemic embolism, and that has a class 1 indication. We recommend DOACs, and we'll over warfarin unless I have moderate to severe rheumatic mitral stenosis or a mechanical heart valve. So that hasn't really changed. If the risk is intermediate, 1 to 2% per year, which equates to an equivalent of about 1 in men and 2 in women for the CHADS-2-VASc score, and we have a 2A recommendation for that. And then if there's low risk, less than 1% per year, those without any risk factors for stroke, aspirin, we felt that aspirin monotherapy for prevention of thromboembolic events has been of no significant benefit, so they may not necessarily need to be on anything. So the decisions based on annual risk score should use shared decision making, and this risk should be reassessed annually. So when we are talking about risk, we wanted to open up to consideration of other stroke risk modifiers, especially in that intermediate risk group, and those that are equivalent to CHA2DS2-VASc score of 1 in men or 2 in women. And you know, I think a lot of us would might recommend anticoagulation in those, but in people who remain uncertain about the benefit of anticoagulation, then you might want to consider other factors that might modify or increase the risk of stroke to help them inform the decision. And some of those factors are shown in red in the bottom, such as higher AF burden, long duration, persistent versus or permanent AF versus paroxysmal, obesity, hypertrophic cardiomyopathy, poorly controlled hypertension, renal failure, proteinuria, and enlarged left atria. So we also wanted to bring in flexibility in using the other clinical risk scores to expand beyond CHA2DS2-VASc. And you see that although CHA2DS2-VASc score is considered the most validated score, and the most therapies as you have used that to prove efficacy, and it's been in many clinical studies. Some of the newer risk scores like Atria and Garfield AF scores might be a better option in selected populations like renal disease. So this table in the middle shows that there are some risk factors that increase the risk of stroke that are not included in CHA2DS2-VASc, and so we went over some of those in the last slide. And on the right, you see some of the three of the other validated, two of the other validated risk models for stroke, including Atria and Garfield. So again, this is another table that goes over some of the risk stratification scores. Obviously, we had CHA2DS2 before CHA2DS2-VASc. CHA2DS2-VASc added several more components to it, more defined age, high, intermediate age category, especially in female sex. The Atria score includes more age categories, renal function, and proteinuria. And Garfield AF has 16 total questions, and it's probably most easily used if you use a web-based calculator. CHA2DS2-VASc has been validated in an Asian cohort, so it could further identify Asian AF patients that might derive benefits from stroke prevention. So after you decide that somebody is a candidate for antithrombotic therapy, then you have to make the choice as to which one to do. And we haven't really changed that. Direct oral anticoagulants are preferred over warfarin, except for mitral stenosis or mechanical heart valve. We do say that aspirin, either alone or with clopidogrel, are not recommended to reduce stroke risk, and that there are no risk factors for stroke. Aspirin has not shown significant benefit. We also, in the guideline, have several, we hope, helpful tables and figures. This slide shows one of the figures that goes over things like renal dosing for the various agents, and liver function by liver function, as well as some drug interaction management. And on the right here, you see some of the follow-up that's recommended. So I'd refer you to the guideline for that. And I think relevant to some of the cases, we do go over anticoagulation in specific populations. They include patients who have acute coronary syndrome, post-MI or post-PCI. And here we recommended for increased stroke risk and PCI DOACs are preferred over vitamin K antagonists in combination with antiplatelet therapy to reduce the risk of clinically relevant bleeding. And for those on oral anticoagulation that are undergoing PCI, that if you can discontinue aspirin after 1 to 4 weeks and continue dual antithrombotic therapy with oral anticoagulation and a P2Y12 inhibitor, that's preferred over triple therapy to reduce the risk of clinically relevant bleeding. For chronic coronary disease, and that we mean beyond 1 year after revascularization, or coronary disease that doesn't require coronary revascularization without a history of stent thrombosis, then oral anticoagulant monotherapy is recommended over combination therapy with antiplatelet therapy to decrease the risk of major bleeding. For peripheral artery disease, we have a 2A recommendation if it's stable, then monotherapy again with oral anticoagulation is reasonable over dual therapy. For valvular heart disease, we've already talked about this, in rheumatic mitral stenosis or moderate or greater severity and history of AFib, that long-term anticoagulation with warfarin is recommended over DOACs. That's because some of the studies that show an increased risk of thrombosis with the DOACs. And then in valve disease other than moderate or greater mitral stenosis or mechanical heart valves, then DOACs are recommended over vitamin K antagonists. Further, for CKD, we recommend, if there's an elevated risk for stroke and CKD stage 3, then treatment with warfarin or preferably evidence-based doses of DOACs or factor Xa inhibitors recommended. And you have the table over on the right that hopefully will help choose your dose. The ones in gray are some recommended doses that have not been studied as well in pivotal clinical trials of these agents. And then we also have 2A recommendations that if they have CKD stage 4, then treatment with warfarin or these labeled doses of DOACs is reasonable to reduce stroke risk. And 2B, if they have end-stage CKD or on dialysis, it might be reasonable to prescribe warfarin or an evidence-based dose of apixaban for oral anticoagulation to reduce their stroke risk. So that's all I have for you right now, and I want to thank you for your attention. Look forward to the discussions with the cases, and again, thank you. I want to thank you for your attention, and also to the writing group, and also acknowledge that some of these slides were modified from an AHA slide deck on the guidelines, which you can access at this link shown on the bottom right. So thank you very much.
Thank you, Mina, for that great presentation. Let me hand it over to you, Roin. Go ahead. Dr. Rekvava?
Yeah. So I think it's time for questions or for discussion. Yes, am I understand correct? Yeah. So for me, Asian population, it's very interesting. Sounds very interesting because the question is how to interpretation of about this Chadvask modified score, because Asia is huge, and the trial was, as I remember, in 2016 or no, before 2016, and it was in Japan. It's held more Japanese population. And where we are in the region of Asia region, and we ask always each other, so where is our just aging, how to say, target, less than 50, 55, or, and is it one score on up to 60 or 65? It depends to 65 or 75. Okay. So I think in this, maybe someone of you having some comment about your patients, that you find that patient less than 65 and they have some risk of stroke, and you can just, in Asian region, you can say that it's one plus, I mean, score. How do you feel it? Because it was in Japanese population, but Asia is huge.
That's excellent, excellent, excellent. You're highlighting the gaps very well, and we need, it would be really fantastic that if this motivates more population-specific study. And I think you're right that what we intended in general was that there's so much validation of the regular chest tube score that we would use that, and if you get stratified into high risk, you don't have to use it. It's mainly in those people who are stratified into intermediate or low risk that we feel that you can use these scores to try to rationalize more anticoagulation. So I think that's where we would use it at this point. But I think you bring up really outstanding points that maybe the MCHAG2-VASc may not be applicable throughout the continent of Asia.
Professor Chung, would you please address something on, as you know, the dosage of a drug? You know, it's a standard dosage. It's recommended according to the guideline. But for Asian population, for example, in my practice, the standard dosage cause several severe complications. Now, for example, like rivaroxaban, from 20 milligram, I taper down to 15 milligram, much better. No patient developed into severe complications, and none of them, you know, develop into a stroke, something like that. So what's a standard dosage for different population?
Yeah, you know, again, that's another area where we have a gap, and you know, I don't think that we were able to address that for the Asian population very well. I think, you know, I think we really do need a lot more information on that. Prior guidelines hadn't really broken out the different populations, and so this is just the beginning. We had a much larger table of other risk scores. So we did a very extensive literature search on all the risk scores out there. And many of them were, you know, I'm talking risk now, so it's not really addressing the dosing issue. But I just wanted to just convey that you know, this is kind of just the start, where we tried to address some more population-specific risk, so this is just the entry into it, from just getting into risk and who needs anticoagulation. And we had pharmacists on the writing committee that tried to help us with this, but to be honest, we did not really fully address the different you know, dosing. And you know, we didn't include even all the other risk scores for risk stratification into our tables, because many of them were not as well validated as just the few that we, you know, did list. So there are a lot of gaps there, and thanks for highlighting that. And you know, maybe we could do a better job in the future, you know, to address dosing. And so hopefully, you know, there will be more studies that will do that. I think we need randomized studies to, you know, give us really good, you know, so that they will hit the guidelines. Thank you.
Dr. Rekvava, do you want to lead us into the next section? This Q&A is great. We want to make sure we get to the cases, and many of these issues that you folks have brought up are actually going to be addressed in the cases. So that'll be good.
So I think it's time to go forward. Yes.
Yes, please.
Let me announce about. So each of our colleagues has for case presentation 5 minutes, as I understand. And first speaker about case presentation noted guidelines documents is Dr. Let me pronounce right way, Ahluwalia, Professor Ahluwalia from United Kingdom. Please, Professor Ahluwalia.
Hi, good morning from the UK, from London, and good afternoon, and thank you to all the committee for inviting me to give this talk. It's been a great session so far, and I hope that this case presentation that I'm going to run through just now will, fortunately or unfortunately, do exactly what we're talking about, which is highlight some of the gaps, which hopefully we can go on to discuss further. So let's start with a relatively typical case of something that I may encounter, that I'm sure you may encounter in your clinics. This is my AI-generated 64-year-old lady who the primary care physician has sent along some information along with her appointment. So she has a history of paroxysmal atrial fibrillation. She has a history of hypertension. They kindly did an echo in the community, which shows a structurally normal heart. and she has a past medical history of coronary artery disease. And so if I was to simply take this information, plug it into an online calculator like the CHADS 2 VASC score on MD Calc, out would come a result, a CHADS 2 VASC score of 3. There we go, job done, right? But what I want to show is that in this case, as with many of these sort of patients that we manage, it's not as simple. Otherwise, we'd be replaced by computers and AI sooner than we think. So I just want to take you through some of the nuances of this case. So speaking to her, the first thing we would do is take a history, and you find out that first of all, her paroxysmal atrial fibrillation is infrequent. And I bring that up because you will see that in the guidelines that Dr. Chung very helpfully took us through, there is reference to the type of atrial fibrillation, but actually, regardless of whether it's paroxysmal, persistent, or permanent, this sort of risk stratification should be performed regardless. Now, I'll come back to AF burden in a minute, but what I want to get across is just because she has infrequent paroxysmal atrial fibrillation does not mean we can ignore the point of stroke prophylaxis and anticoagulation. It is something that we need to consider. Then again, taking a bit more of a history from the 64-year-old lady, we find out that her hypertension is actually very well controlled. And that's important because in the guidelines, again, it does give us a little bit of guidance on what we should consider to be significant hypertension to prompt us to increase our risk of stroke in this patient. And it demonstrates that if your resting blood pressure is above 140 systolic or 90 diastolic, that's when alarm bells should start ringing. It mentions the Aristotle study where even a single elevated BP measurement increased the risk of stroke by 50%. So Our Lady actually is very good. She manages and controls her hypertension very well. And I think what's also important to clarify here is, are they on medication or not? Because that would also influence how to interpret this patient's hypertension. Knowing that she has had an echo with a structurally normal heart is important. As you heard, that means that there is a low likelihood of hypertrophic cardiomyopathy, impaired left ventricular ejection fraction. All these things are positive indicators. And then finally, on to coronary artery disease as a past medical history. Again, the guideline and all the evidence guides us a little bit more to how to interpret this. And we know that what should be significant is a history of myocardial infarction, coronary intervention, angina. And for Our Lady, we find out that actually she does have some distal, probably mild residual disease, but not something that qualifies as coronary artery disease according to these guidelines. And so if we take a step back and apply a personal touch to the risk stratification score, you could argue that this may be a case where CHADS VASC score is actually closer to 2, 3, and no real trigger for a Hasbled score of 0. So really, I'm not saying that one answer is right or one answer is wrong. What I want to show is there is a lot of nuance, and I think that's the key thing to take away from here. And there's a lot of nuance in this sort of case that we are going to be confronted with every day. And this is where really then the further modifiers I think are incredibly helpful, because if you're in this gray area, what you can try and use to pull yourself out a little bit is if there's any evidence of these other risk stratifiers. How much is her AF burden? Is she overweight? We haven't even touched on that with this lady, but actually, what is her BMI? Would that affect things? What is her left atrial size in that echo, right? Getting a report that says structurally normal is not good enough. We need to know the numbers when we're interpreting this patient's results. Then looking at the renal disease is another modifier, something that's also very important. And again, very interestingly, this lady is 64, as they always are when you have to make these sort of decisions. And that takes us back to this importance of doing annual reviews or, revisiting this idea of stroke prophylaxis regularly. And I think that's probably one of the reasons why paroxysmal atrial fibrillation should not be disregarded. We know that AF is a progressive disease, and you sitting across from this patient is an opportunity to make an intervention that may have lasting consequences. You're not sure when her next interaction with a healthcare provider who's going to consider this topic will be. So, how soon will she turn 65? What are her thoughts? And I think really, just to finish off, this has got to be a patient-centered decision. Our job is to inform the patient of all these nuances of the evidence we know, and unfortunately the things we don't know, so that they can make a informed decision based on this, especially when the evidence is a little grayer. And I like the idea of visiting the annual risk, especially as all of these factors, not just age, renal disease, echo parameters, BMI, burden, all will change over time. And so it's important we keep revisiting this. So that's the end of this case, but I hope it's brought up a lot of topics we can go on to discuss further.
Well, thank you, Dr. Ahluwalia, for this excellent presentation. Well, it looks like that you are hesitating to recommend oral anticoagulation for this young lady. What would you like to recommend her to prevent or to reduce the stroke risk?
Yeah. So I'm not, at the moment not hesitating. I think the whole purpose of our job as physicians is to gather more information, right? To make a more informed recommendation discussion with this patient. And so, we cannot act on just a referral letter. We need to have these conversations, find out all these risk modifiers from the patient to make that happen. Now, I think there are some things which are unequivocal, which is making recommendations about lifestyle, monitoring AF management, understanding the risk, understanding things that she can do to stay healthy. She's doing a very good job of managing her blood pressure, very good. We know that she has some mild coronary artery disease. We need to make sure that is aggressively managed to make sure that doesn't progress. So I think managing the risk factors is a non-negotiable in terms of my recommendation. In terms of what to do about the anticoagulation, I think that's where things get a bit grayer.
Right. That actually emphasizes the point of Dr. Chung about the decision based on annual risk, stroke risk, rather than just specific stroke, specific cause or specific score, risk score. And now I would like to turn to the panel, asking their opinions about the anticoagulation in this particular case. Can we start from Dr. Mungun?
Hello.
Would you straight give oral anticoagulants to her, or just would you like to just wait and get more information about?
Well, actually, I also have to be, how to say, based in my continent, in my country condition, and that is meaning that, well, for this patient, of course, it's ideally maybe you can give the anticoagulation, but in Mongolia, for example, we do not have availability of anticoagulation. All those things are difficult. Not all the patients are very accessible. So in this case, of course, the risk factor modification is priority for us. We try to do as much as possible. And here, I also wanted to discuss with our panelists about what would you think about a pocket pill in the pocket strategy. For example, we have a countryside patient who has a relatively low risk, and the AF is not frequent, so she will have sometimes a risk, and the medication is very expensive, and the accessibility is very low. Sometimes we can advise them they can have pill in the pocket whenever they start to feel the AFib episode. They can initiate the medicine and they can stop for some times. So my opinion, I will indicate Xarelto, and then sometimes for some patients I will advise such as.
So Dr. Mungun brings another issue for discussion, pill in the pocket of anticoagulant. So Dr. Jiang?
Yes, Professor Otto. And this old lady, and it's slim. His BMI is not so high, and her episodes of AF is not so frequent, and her blood pressure is well controlled, and her coronary artery disease is not so significant. So yeah, it's really reluctant to make a good decision. I needed to discussion with the patient to obtain her consent. What's the benefit and the risk of the anticoagulation, and also the dosage of the pill. For me, I I agree with Dr. Mungun. If the patient, if episodes, it's always symptomatic, maybe it's a good idea to take a pill during episode, but so far no evidence is based on this point. So really, I think this is a gap in current situation. That's my opinion, Professor Otto.
Thank you. Thank you very much. Now I would like to turn to Dr. Emkanjoo to have her opinion about this case.
Hello, everybody. In my opinion, anticoagulation should be started for this lady. The gap exists in great variation in risk of stroke depending on a dynamic risk factor like hypertension. It's a non-binary. Yes, yet it is unclear how to best manage patient according to guideline. For example, how should risk of stroke be assessed in a person with hypertension in whom the blood pressure is very well controlled? Or how do we incorporate AF burden on the risk calculation? Periodic assessment is very important in patient, and periodic assessment should be performed once a year, and this lady in 1 year will be 75 years old and get another point for starting the anticoagulation. And as you mentioned, the additional factors such as degree of hypertension control is very important and can also affect the risk of stroke. And in Aristotle trial, a single elevated blood pressure measurement during that study was associated with a 50% increase in the risk of stroke. But according to me, the anticoagulation should be started in this lady.
Well, thank you very much. Now I have Dr. Gül to comment.
Thank you, Professor Otto. It's a nice case. You know, I will ask the question in different ways. So why do we follow the guidelines? Is it just to guide our therapy or to protect ourselves from the medical issues? I think from the medical point of view, yes, I will start anticoagulation because in case of any the issue, they're gonna, I mean, it's gonna be against me. But I think in a knowledge like the patient, if patient has paroxysmal AFib, first of all, if she's symptomatic, I will go for catheter ablation as a first choice if service is available. And then after ablation, if the burden of AFib is still low or zero, then I can open discussion for whether we should stop anticoagulation or continue. But at this point, with ongoing AFib, even it's paroxysmal, I will definitely start anticoagulation for this lady. Thank you.
All right. Ayan, Dr. Abdrak-hamanov.
I agree with Dr. Zahra. I think we should start anticoagulation therapy for this patient. I don't agree with symptomatic atrial fibrillation. If we do sometimes Holter monitoring, we can find how to say it, we can find some episodes of atrial fibrillation that patient couldn't
Asymptomatic,
know.
yes.
Asymptomatic, yes, asymptomatic. Yeah, that's why I think we should start anticoagulation therapy with this patient.
Well, thank you very much. Now, it looks like we have a divided panel. And then I would like to go to the author of the guidelines, Dr. Chung again, to be a referee, perhaps, you know.
May I comment before Professor Otto? Before Professor Chen summarize it? So for me, these numbers is interesting. 3 CHA2DS2-VASc and bleeding risk 0. I would like to go to anticoagulate this patient because sometimes modified factor as an hypertension does not work in our country. Sometimes today patient has good blood pressure numbers, but tomorrow they are not in. And question is, your AI created lady, is she Asian or European or another race? And for me in this situation, one more point is very important as a clinician. So LAA type, if it's more thrombogenous LAA, they have we find it from TE, yes, more anticoagulation. If we find it, it's not thrombogenous left atrial appendage.
So
more
you would
no.
like to have an MRI?
Okay, I'm ready.
All right. So how can we have a compromise, Mina? And
Everybody,
how can we fill the gap?
everybody brings up so many good points. We do, there is a randomized study going on looking at pill in the pocket, React AF. So we'll get more information on that in a few years, hopefully. But, I think I hear, some people talking about, it is a 2A indication. So I, like you, would probably recommend anticoagulation. But I think doing the shared decision-making with your patient, bringing up all these factors, you're almost going to be 65, et cetera, and maybe the population you're from, I think that makes a lot of sense to just really individualize the decision with your patient. It's the gray zone, but
I think that's a very good summary point, Mina. I think you all brought up great points about, we did have a divided group, but you brought up additional factors that we should consider in making the decision. And that's what makes the art of medicine, not just purely the science of medicine. And we've got to be honest and humble and realize we can't always provide answers to everything. That'll give Mina an opportunity to be co-author or lead author on many documents going forward. In the interest of time, I'm going to move us on to the second case. And I appreciate all the great commentary led by Ali and the panelists and the presenter on the first one. So for our second case here, we're very fortunate to have Dr. Irakli Ninua from Georgia. You want to present your case, and then we'll have Dr. Odo open it up to the panel.
Hello, thank you. Our today talks about oral anticoagulant approaches. It looks like not so directly as I thought. My case also like standard, but there is few interesting things. When we are starting thinking about anticoagulation, we just summarize stroke. Does patient need stroke prevention, and what is the bleeding risk? Patient, 70 years old Asian male with condition paroxysmal atrial fibrillation. Cardiac status is normal left ventricular ejection fraction and no valvular disease. Also, he has chronic kidney disease, the stage 3B, and weight 100 kilos, diagnosed with sleep apnea. Also, tobacco abuse and early dementia. We have many data. For the start, CHADS-2 scoring system, which was developed in 2001, it says that this patient just has 0 point and it's in low risk. Afterward, the CHADS-2 was scored by the patient in a risk age group and develops 1 point. And he is on 2A risk score for anticoagulation. But we have many data. The patient has chronic kidney disease, weight, tobacco abuse, and etc. We need some kind of tool which we will provide. We have information, but we don't have enough opportunity to use it with CHADS-2. And the Atria score has some kind of answer on it. Here is additional points with proteinuria and kidney disease. And this patient has 5 points, but still with low risk. And also with atria, we have same atria bleeding risk, by which this patient has just 0 point and less than 1% of bleeding. But we still have information about his early dementia state, his tobacco abuse. We don't using it, but intuitively it has effect on thrombus. development. And for Haspelet scoring systems, this patient has 1 point, but risk is 3% of bleeding annually. And we have Garfield-Ave score, where we just can also input this information, like early dementia, tobacco use, and also we provided this information to patient. And with these graphs, the patient very well understands this condition. We shown them what will be his annual risk of mortality, ischemic stroke, and major bleeding. And patient agreed with opportunity to determine anticoagulation. And the choice was apixaban because of his Asian nationality and also renal disease. You know, everyone, apixaban has lowest extraction from renal, and that's why it has less bleeding scores, which provided 2023 American study apixaban versus warfarin and rivaroxaban. Thank you.
Well, thank you very much. This particular patient, again, brings us to the point that the decision is not really always possible with an isolation of a single scoring system. So I would like to turn to the panel to ask them how they would like to decide on this patient, what kind of information they would like to really have, and how they use the risk score systems in their practice. Could we start with Dr. Jiang?
Okay, Professor Otto. Yeah, it's. I think it's. I'm struggling for this patient. You know, his
Just
renal
1 second. Could you, Dr. Nino, could you stop sharing the screen? Okay. All right. Yeah, go ahead, please.
Okay. This patient is a 73 years old Asian male, and he has atrial fibrillation, and otherwise he's also he had has chronic kidney disease, and his GFR only 35 ml per minute. So I'm very struggling to make a decision if the patient need anticoagulation or not, because according to my own experience, the GFR sometimes deteriorate very rapidly during a certain period. So I needed a very good consent, very good discussion for the patient to ask him to check the renal function before I offer the patient, prescribe patient anticoagulation. And the DUAC, I would prefer the apixaban first.
All
That's
right.
my opinion.
Thank you, Dr. Gill. Could you also comment on the possible use of left atrial appendage occlusion in this particular case?
Thank you, Professor Otto. I think regarding the appendage closure device, I wouldn't consider this patient based on the risk factors that the patient has. But what I will, in terms of, because yes, we have some modifiable risk factors. They're strong risk factors, but they're not strong enough to encourage us to put the occluder there. I think I wouldn't do LA occluder. But in terms of anticoagulation, I think it's a tailored approach. I would anticoagulate this patient first after the certain discussion. But what I will do later on, I will ask, if possible, if patient is able to reduce the weight, if patient is able to get treated for sleep apnea properly, if patient is able to quit smoking later on, then I can stop anticoagulation maybe later. But with this current, with the recent, the modifiable risk factors, I think I will go for anticoagulation, but this is not for life. Maybe this anticoagulation can be for temporary.
All right, thank you.
May I
Dr.
comment
Abdrak-hamanov,
something? Excuse me, may I comment something?
just I will give you
Yeah, excuse me,
after the
just a
panel,
comment
sorry.
of the Enis. Okay, excuse me.
Yeah, okay. Doctor, where is
I
Ayan?
agree. I agree with my colleagues.
Okay.
In this situation, these patients, we think start with apixaban. We think anticoagulate these patients and try to modify his life, try to quit smoking, treat apnea, and so on.
All right, Roin, please.
But sleep apnea, body mass index, and the third one, I don't remember. This, I mean, this, we have not discourse in guidelines. So, okay, it's great that we modified it, but according to the guidelines, it's nothing about to give anticoagulation or not.
All
That's the
right.
question, big question. That's why I'm not sure that when I see those patients less 40 kilogram before he was, I stopped anticoagulation therapy. This is our patient. We gave to him anticoagulation, of course, but I'm not sure that those, I mean, signs are enough to just say to him, no, now you are 75 and you don't need to have anticoagulation. That's the question.
All right. Dr. Emkanjoo, please.
The decision to treat with anticoagulation in this patient or choosing a occlusion in such a patient with a CHA2DS1 may at times require additional discussion with the patient, as the strength of recommendation is less robust. In low-risk patients like this patient, Garfield may be offered superior discriminatory value in predicting all-cause mortality and stroke compared to CHA2DS1. Regarding the sleep apnea treatment, there is not RCT showing that treatment of sleep apnea could reduce the recurrence of AF. I discussed with the patient and after make a decision to start the anticoagulation.
Thank you. A short comment from Dr. Mungun, and then I will again finally turn to Dr. Chung about the guidelines.
Well, we are discussing about scoring, so I would say I will use all the possible scoring for this patient because a single scoring is not matching well. For example, CHA2DS1, we are considering about 75 and above, but males in Mongolia living no more than 67, so we are not even reaching 70 in terms of life expectancy. So I would use multiple scoring systems for the patients to make decision.
Dr. Chung?
Yeah, I think we're all pretty much on the same page. You know, I think we all kind of agree this is like a patient in whom CHA2DS1 is not covering everything. And we in that table for things that aren't covered by CHA2DS1, obesity, BMI greater than 30 is one of the risk factors that has been associated with higher risk. So yeah, the renal, proteinuria, I mean, there's all those things. I think you just would bring that in, use the additional risk scores, and I'd probably, lean toward anticoagulation and, do that shared decision making again with the patients in that direction.
Thank you very much. And the floor is yours, Tom.
Thanks again for the discussion on this case. We want to make these cases controversial where there isn't an obvious black and white answer. I think it's very good that what this case did bring out is, the concerns, and it also brought to the forefront, does modification of risk factors actually make a difference? And how one needs to look at the fact that there is not one gold standard, i.e. a specific score that everyone must use, but looking at it in the totality and then having shared decision-making is important. I'm going to hand it over to my co-chair, Dr. Roin Rekvava, to introduce the last speaker, and then we'll go from there. Roin?
So the third speaker he's from Turkey, Mr. Serkan Okutucu. I'm not sure that I'm pronouncing it. Please, Mr. Serkan, Dr. Serkan.
Thank you. It's correct. Dear distinguished colleagues and guests, good afternoon from Ankara, Turkey. I am Serkan Okutucu. In the following few minutes, I will briefly share another AF case with you and few details about this case. Our case is 77-year-old male. He admitted with palpitation for 3 days. As we can see ECG on the right side, he has the AF with rapid ventricular response. And from past medical history, we learned that he had previous persistent AF episode. He was placed on warfarin and underwent cardioversion with no further AF for 6 months, and his INR have been in therapeutic range while on vitamin K antagonist. He has hypertension. He is currently on valsartan and amlodipine combination, and he has COPD. He is using sometimes systemic steroids. He has degenerative joint diseases, and he uses sometimes the ibuprofen as needed. Also, he has another comorbidity, chronic coronary disease. He had a PCI of obtuse marginal branch 4 years ago, and he's on still on dual antiplatelet therapy with no recurrent chest pain and negative stress test 3 months ago. And his primary care physician stopped his vitamin K antagonist. And his current medications are, as we can see on this slide, with acetylsalicylic acid, clopidogrel, atorvastatin, and valsartan amlodipine. And Professor Otto, should I continue about the...
Well, yeah, I would like to ask you, Serkan, are you happy with this antithrombotic regimen, or how can you really, would you like to adjust or refine?
Yes.
Yeah.
We need to modify. I will briefly share how I approach to these patients, and so we can get also the comments of the panelists. So for this patient and for all AF patients, we should have holistic approach to the patients as guideline recommend. So we need to evaluate the stroke risk. We need to optimize all modifiable risk factors, and also the symptom management is also another important aspect. So let's look to the stroke risk of this patient. He has CHAS-WAS score of 4, 2 comes from age, and 1 comes from hypertension, and 1 from the coronary artery disease. So this accounts around 4 to 5% of annual risk of stroke, which is really high. So we need to anticoagulate this patient. Then let's look to the bleeding risk. He has bleed score of 3, 1 coming from the uncontrolled hypertension, and 1 comes from the age, and 1 also comes from the DAPT, and also NSAID, and even systemic steroids. So this also, we can modify this has bleed score for this patient. So when we look to how we should approach this patient regarding with anticoagulation, he has more than 2% of annual stroke risk, so we need to anticoagulate, so preferably with DOAC. Although this patient has good TTR, I choose the DOAC therapy for this patient. And when we assess the Garfield AF risk calculator, also we can see that the DOAC has a better profile for this patient. And regarding with the chronic coronary disease, we can see that this patient is beyond the 12 months after intervention, so we can just give the DOAC alone. So for this patient, I just initiated the DOAC alone. So the treatment plan for this patient is to commence the DOAC, and we did TE for this patient, and there was no thrombus in LAA, so we did cardioversion and successfully restored the sinus rhythm. And we continued with DOAC monotherapy, and we recommended pulmonary vein isolation. We can discuss about this a little bit, and also we continued with the amiodarone 200 milligram until he decided to have the intervention or not. And another important topic that this guideline point out that he has bleed score of more than 3, so we need to assess the hemogram, the renal function, and kidney, the liver functions of these patients for every 3 months. And thank you for your attention.
Thank you, Serjan. You very elegantly outlined the guideline directed therapy. But I have one question to the panel. Besides their opinion about the anticoagulation of this patient, we have the data of frail AF presented at the ESC this year and published also later on. So based on the data of frail AF, how would you like to adjust or change or modify the anticoagulation of this patient? Could we start with Zahra this time?
I recommend anticoagulation with this patient as a monotherapy because we have enough landmark clinical trial that showed that monotherapy is enough for this patient. And then I recommend the PV isolation for this patient.
So would you like to recommend to stay on vitamin K antagonist based on the data from the
no, I
or
recommend
just you would like to recommend, as Serjan recommended, a DOAC therapy?
I recommend dual therapy for this patient, not warfarin.
Right.
Because as I said, we have the landmark clinical trial that show the efficacy and the superiority net clinical benefit of DOAC compared to warfarin in these patients.
Right. So thank you very much, Dr. Mungun.
Well, I think Dr. Serjan already did a very good management for the patient, and my opinion will be the same.
So you follow Dr. Serjan Okutucu's recommendation?
I would.
All right. Enis?
Yeah, I think I do agree with my colleagues that I will do the same. I will continue with the DOAC. And of course, definitely the PVI will be one of the cornerstone treatment here. And maybe later on in the future, we can consider even appendage closure in this case. I mean, I know it's not clear evidence, but with the CHA2DS2-VASc for patients aging and is going to be a fragile patient in the future, I think still the LA occlusion can be one of the consideration here.
Right. No, again, you're not really in favor of vitamin K antagonists.
No,
based on
unfortunately.
frail AF data. All right.
No.
So, thank you. And then now we have Dr. Jiang.
Yeah. Like I said, I think this is a wonderful case for discussion. This is also a controversial issue for patients with new onset AF only for 3 days. And the patient, though according to the guideline, the patient need anticoagulation. And the patient comorbidity with CCS, chronic coronary artery disease. So I think DOAC it's recommended. But as we know, in the old era, patient with one episode of AF, and it's converted to sinus rhythm for 6 months, we can stop anticoagulation. So it's a controversial. So I need your opinion, Professor Chung, to make it clear.
All right, we'll come back to Dr. Chung. Now Ayan are you there? Yeah. Could
Yes,
we have
yes,
your opinion about this?
I agree with my colleague. It's a good management, I think. Yeah. I'm no added.
All right, thank you. And finally, Dr. Chung for a brief comment, and then we go back to Tom for concluding remarks.
Yeah, I think that, probably would not want to discontinue anticoagulation just because their chassis VAS score, their risk scores are so high. So even after cardioversion, you probably I would continue. And thank you for bringing up the frail AF trial. And I'm keeping a list of all the things that you're bringing up that are gaps in our guidelines. So thank you. Well, that obviously came out after we put together the guideline, but it's really another wonderful thing to add for the future.
All right, thank you. Thank you very much for the great discussion to our distinguished panel. Tom?
Thank you very much, Ali. Before I close, Mina, I do want to pose a question to you. I think what this case brought into, consideration is an individual who has multiple comorbidities and maybe taking medications that can augment the bleeding risk, such as steroids for COPD and nonsteroidals for degenerative, arthritis and CAD, with dual therapy there. And that is a situation that is not uncommon in an elderly population. And then the other thing is this patient had been compliant, had TTRs that were great. So what do you think about someone who actually would prefer to take warfarin or had done well on warfarin with consistent times in the therapeutic range? I know we all want to modify, and I think that was very good what the panel has said about trying to get rid of all those other medicines if at all possible. But please address that other question. I know it comes up commonly with patients. Why do I need to change for a more expensive drug when I'm doing well? Your thoughts?
Very common, and I talk to them. I often, the cost is prohibitive, and so I have patients who will stay on warfarin. I usually bring up the lower risk of intracranial hemorrhage with all the DOACs compared to warfarin, and I also bring up the significant difference, at least statistically, for better survival on some of the agents. So that's the rationale I usually give my patients when we're doing shared decision making about changing. So
that makes perfect sense. Well, first of all, I want to thank everybody for participating in this great conference. Ali, you did an amazing job of keeping people on time and getting succinct but relevant commentary. So I thank you very much for that. I want to thank the panelists for their excellent commentary and raising important insights that I think really made the educational effort better and made our understanding and our management of patients even, more advantageous. And lastly, I'd like to thank the folks that presented cases. I think you did a great job of raising some of the controversial areas that are there. Remember this conference, we started off with 4 Gs, the goals. We wanted to, address controversial areas, the guidelines. We wanted to bring in the recent update and see how that impacts on practice, and then the gaps. And we realized that the guidelines have addressed some of the gaps, but the gaps will always remain. Potholes are everywhere and always will be everywhere. And then getting it right. And I think getting it right is a commitment that we as clinicians and as scientists make by consistently looking at the gaps, trying to address them, and trying to do the best we can by engaging colleagues like we all did here, getting second, third, and fourth opinions, and then trying to, most importantly, engage our patients, in the discussion. So the way I look at it is there's foundational considerations. Scientific studies that are well done formulate the first phase of that foundation. The guidelines then synthesize it. So clinicians have a handy workbook to deal with to address those issues. And then I think educational programs like this are very helpful. Personally, I like ones that leave things up in the air and don't provide absolute answers. It, to me, is food for thought and fodder for going forward. And I think that's what we do. Medicine, as I said earlier, is an art and it is a science. I do want to thank all of you for your participation and for your interaction. And I think it's by doing these things in a global manner and engaging multiple societies that we get better. So Roin, I'd like to let you have the final commentary here, you know, given that this is a joint session. Give us your thoughts and maybe some suggestions for future interactions.
Yeah, thank you very much. So I just understand that we need like these education programs we did today. And thank you very much for Professor Chung. She's excellent talk about summarize about guidelines. Thank you all panelists also, or all speakers. It was very interesting. It were very interesting case presentations. I listen a lot of minds about anticoagulation, ablation, LAO, occluder implantation, and etc. Thank you very much. And I think we should do like these programs more so frequent to understand mind of all of you. Thank you very much.
Very nicely said. I think that, you know, is an important commentary. Again, thank you to all of you for joining us. Ali, as the president of the World Society of Arrhythmias, would you like to make a closing comment and then we can all log off?
Well, thank you, Tom. As Tom said, we are planning educational activities similar to this with other societies jointly. And we try to reach out the underserved areas and disseminate knowledge and try to train everyone who is involved in arrhythmia management. Thank you very much and look forward to seeing you all in another educational activity of World Society of Arrhythmia.